In the spirit of the Stewart Award and of Alumni Day, where we're looking back on where we've been and talking about where we are now and where we're going, I'd like to talk about immune biomarkers of past and present, which I think is a nice way to also look back at Memorial and our deep-rooted history in immune biomarkers and immuno-oncology. So William Coley was largely regarded as the father of immunotherapy. He didn't always make good decisions, though. As you can see, he was a surgeon, probably trying to be an immuno-oncologist at a time when it was very unfavorable. But he worked at New York Cancer Hospital, which later became Memorial Hospital. And in 1891, he reported a bacterial toxin treatment for cancer, which was later called Coley's toxins, which in 1899 became commercially available for about 30 years as an adjuvant to surgery and radiation. And eventually, he was eclipsed by Dr. Ewing, who promoted radiation over immunotherapy, and immunotherapy went into some dark times for another few decades. This was the New York Cancer Hospital on the left right here, which had this very distinctive architecture with these round wards with this very advanced ventilation system in the middle of it, shown here. And then it was thought that by not having corners, you didn't allow any place for the disease and blight to hide out in. It did well in the beginning, and then it fell upon some difficult times. Eventually, we moved to the east, and it became a nursing facility, which was shut down. And then it was vacant for a while, and many decades later, it was reinvigorated, as most things are in New York, by private equity and funds, and it came back as residences, which you can see in 2015 in the bottom picture. So I'll be speaking a lot about how we got to where we are in regards to immunotherapy and biomarkers, and then a little bit about new technology that we brought on here about 10 months ago, and some of the promise that we see for that technology. So regardless of who you look at here for the history of cancer immunotherapy, many people start with the Coley's toxins in the 1890s, but then as you can see, there was this dark time, and decades passed, and we reemerged in the 1960s with adjuvant BCG. We then came in the 70s to show the immune component of spontaneous regression in melanoma. We had adoptive immunotherapy for patients with cancer, and hybridoma methodology was evolved. Interferon alpha was improved as adjuvant therapy in the 90s. It was expanded upon in the later 90s. And that brings us really to 2000 to 2010 with some more notable drugs such as Avastin making the market and history. But what we generally think about when the recent alumni look back are really these big drug names from 2010 on. So we think about immunotherapy as ipilimumab or nivolumab. We think about CAR Ts that are on the horizon and integrating this all together with combination therapies, which are clearly in full steam ahead here at Memorial with dozens of combinatorial trials underway. It's certainly a very exciting time, and our good friend Soldano Ferroni at MGH put together this more cultural view of the renaissance of immunotherapy, which during his time, really, the enthusiasm phase was in the 1960s. Then we entered another dark skepticism phase, and then we reemerged with a renaissance phase now, which seems to be stronger than ever. So it's a great time to be in immunotherapy, specifically in biomarkers, as the number of therapies that have come to fruition has far outpaced the biomarkers, and there is a deep need for personalization of immunotherapy. So this didn't turn out very well. It looks like it didn't transfer, but essentially all of the yellow blocked out boxes said checkpoint therapy. So it doesn't really matter where you start for metastatic melanoma treatment. Essentially all roads lead to checkpoint inhibition therapy. And your default at the end is either checkpoint therapy or chemotherapy, and more so that's additional mechanisms of immunotherapy. And so what this has done is put an immediate deep scrutiny on this co-stimulatory and inhibitory interactions, which we seem to see over and over again. And to not beleaguer it with too much time here, we're really concerned with a handful of cells, with the T cell being most fundamental in the middle of this picture, and its interactions with tissue macrophages, dendritic cells, and the tumor. And we constantly see these arrows in which show either inhibitory or stimulatory functions on the T cells. And many, if not all, of the molecules that you're looking at in this schemata from 2013 are well into clinical trials here at Memorial or elsewhere. And so we've come up with, based on the successes of CTLA4 and PD1, some treatment paradigms for why these are working and how it's influencing what we see in biomarkers systemically. And we talk about the priming phase of the immune response, that is the T cell interacting early on with the dendritic cell. We see MHC engagement of TCR, the activation signals can go. And then the inhibitory signals with CTLA4 and B7 are blocked. And it's thought that what happens here at this early stage essentially induces more of a systemic response, and you can see much more impact on the peripheral circulating T cells than you see in the effector phase interactions that we block later downstream, which tend to be more focused on the tumor T cell interaction, and certainly drives more of a need for us to look beyond what we see in peripheral blood from the early IPI studies and more at what we see on the tumor T cell junction side of it, which you see TCR, MHC interactions, but then you also are blocking this PD-L1, PD-1 interaction, and that's inducing many changes in the tumor microenvironment that we're hoping to dissect out. So the CTLA4 blockade with ipilimumab was approved for monotherapy very recently in 2011 with advanced melanoma based on an 11% response rate and prolonged survival in those of about 22%. In 2015, it was approved with combination therapy for PD-1, and there are currently dozens of ongoing combinatorial trials. PD-1 blockade was even more recent. It was approved for advanced melanoma in 2014 with durable responses, either partial or complete, in about 30 to 40% of melanoma patients, about 20% of non-small cell lung cancer patients, and about the same number of renal cell carcinomas with extended overall survival compared to conventional therapy. And again, in 2015, it was combined with IPI. But there are so many problems that we have right now that we can't answer. So it's not effective in all cancer types. It's not effective in all responsive tumor types. You can see delayed or mixed tumor regression, which has mandated different ways of monitoring these patients radiologically, many of which were originated at Memorial. And you can see so many side effects from these that we don't understand in regards to why they're occurring or which patients they're going to occur in. So we certainly need biomarkers to guide initial therapy, to provide on-treatment indicators of response and markers of durability or resistance. And when we talk about biomarkers, I think Michael gave you a great overview of biomarkers in general, but clearly we have genetic biomarker-driven therapy with kinase inhibitors, and we have BRAF V600E staining, which is we'll hear more about. There's an adjunct for risk management, so this is really an unmet need right now in biomarkers. There's about a 20% serious adverse risk profile for ipilimumab, and we don't know who's going to be at risk right now. We need biomarkers to identify the subset of responders, and we do this okay right now in colorectal carcinoma with genomic instability, patients responding to PD-1, and then we need to predict and manage response likelihood as well. And we do this with PD-L1, and of course, historically in pathology, we've also done this with ER, PR, and HER2, but now we're looking beyond that into immunotherapeutic applications. And so there are a variety of oncogenic immunosuppressive mutations which impact immunotherapy. So some are more well spoken about, and we'll talk about that in the ensuing slides. But then there's also data showing that BRAF V600E mutant melanomas secrete soluble factors that inhibit dendritic cells, that these 9p24 gene translocations or amplifications, which is where PD-L1 and PD-L2 are, can be seen in Hodgkin's and mediastinal diffuse large B-cell lymphoma. And ALK activation constitutively in lung and lymphoma can increase PD-L1 by STAT activation, and that P10 deletions in GBM can increase PD-L1 by PI3 kinase AKT mechanisms. And then more recently, in 2016, NRAS mutant melanomas have been shown to be have an improved response to immunotherapy sort of across the board. And it might be secondary to increased mutation burden in those or more mutation specific. So when we look at mutational load and density of tumors, this has really gone, sort of taken the lead as genetic biomarker for immunotherapy, but it's in many regards opened up many more questions than we have answers. So the higher load, the better the response to immunotherapy. And we see this in PD-1, PD-L1 therapy for melanoma, non-small cell lung cancer, squamous of the head and neck. We see it also, but to a lesser degree, in IPI monotherapy for melanoma, and MSI status predicts response to anti-PD-1. There's about a 60% response in MSI tumors in an early 3-arm trial. So we're used to now seeing this somatic mutation figure, which was published in 2013 in Nature, showing the number of mutations per megabase on one axis and the tumors lined up. And the melanomas, the lung squames, adenos, esophageal, colorectal, and bladder tumors tend to be on the high end. But we've now pushed a little bit beyond this to show that these tumors which have a high somatic prevalence also have a much more frequent formation of neoantigens, with the middle group being shown here and then occasional neoantigen formation in the below group. The problem is that there are numerous mutational load challenges. There's no clear numerical cutoff for response. there's a twofold range within individual cancers. This is still a probabilistic model, which is imperfect, and there are outliers on both sides. So that is, there are high mutation tumors that show no response to current immunotherapy, and those with a very low mutation profile that have fantastic response. And we can't predict which ones those are going to be, and we can't yet predict the relevant neoantigens. So there are also downstream issues that I think Michael's going to be tooled up to address, and there's going to be an endless stream of people at your door knocking for neoantigen assessment. So the expression of neoantigens is one issue. Knowing that they're there and expressed can certainly be used or can be assessed by mass spec or IHC. But the problem is that we now know that most of these neoantigens are very personalized neoantigens. There's not a lot of consistency of neoantigens from person to person, and therefore developing IHC for picking up these neoantigens is likely not to work well. Mass spec might be a better technique to do this, but then you have to consider that not only making the neoantigen is critical, but you need to be able to present that neoantigen with class 1 or class 2 to a functional T cell population. And we now know that there's a component of beta-2 microglobulin loss with downregulation of class 1 or class 2. There are processing problems for neoantigens before it even gets to the class 1 or class 2, and there can be epigenetic silencing throughout areas of the tumor, so you might have it in one region of the tumor but not in other areas, and we still have to deal with these problems. Not to mention the fact that you still have to have a functional T cell population downstream of your presented neoantigen. So where we are for mutational load testing is that exome sequencing is fantastic. Most neoantigens occur in exons, so we can pick up the majority of neoantigens by doing this, and we can get a nice assessment of mutational load. Unfortunately, it's also been shown that most neoantigens are not recognized by autologous T cells, so figuring out which ones of those neoantigens are going to make robust T cell activation neoantigens is yet to be determined. And then we also, of course, have done for a long time a fairly good job of predicting MSI status by IHC, and we're now doing it by other modalities. So when we look at, we're going to shift now from genomic biomarkers to what my little lab, which started about 10 months ago or so, does, which is look at immunologic biomarkers to support immuno-oncology. And this is a field which is really been publishing quite a bit for the last 20 years or so, and it's reflected in the fact that some of these modalities and testings have nearly made their way into the clinic. So intratumoral lymphoid infiltrates, as you know, are really diverse, but most of the data is within the CD8 or CD3, CD8 population of antigen-experienced cytologic T effector cells, which are marked by CD45RO and granzyme. And a big bulk of this data is within the colorectal carcinoma studies, which show that the higher the infiltrate of the cell population within the margin and the center of the tumor, the higher the likelihood of survival and long-term response. So it's outperformed clinical staging criteria in low-stage disease. It predicts better disease-free and overall survival. And you can also see correlations with melanoma response to anti-PD1. You see an improved prognosis in 58 out of 60, or about 97% of reports that look at infiltration of CD8, CD45RO T cells within the tumor. And this has been shown in ovarian carcinoma with increased CD3 positive T cells at the margin and center, showing increased progression-free survival, increased overall survival, in colorectal carcinoma with both microsatellite unstable and stable tumors benefiting from protracted progression-free survival and increased overall survival. And then you can further refine this, and this was an indicator, an early indicator, that perhaps looking at this at a much more refined level would give us even more valuable information, and that is if you look at the gamma granzyme positive populations, it can be even, it can broaden the differences even further between the responding and non-responding populations. And so this has all been summarized for us here in a nice Nature Reviews paper, which essentially lines up the tumors on the left and then the positive. This is a number of articles on the bottom axis, with positive prognosis being delineated by green, no effect in white, and negative prognosis in red. And you can see that the majority of cases, when they look at CD8 positive T cell density and survival, colorectal, of course, leading the way, followed by breast second after that, show a positive prognosis with this infiltrate. But there are some very notable outliers, and it's important that there's a lot of work to be done here in refining this data across subsets of tumors and also in different molecular categories of these tumors beyond actually looking at more markers on the slide. So this can certainly be broken down more effectively. And so you see some of the studies show a negative prognosis in head and neck, in prostate and esophageal, and then both in renal cell carcinoma primaries and also in metastatic disease. And then there are certainly a handful of studies that show no effect on prognosis in gliomas, MPNSTs, and otherwise. So it's not a universal truth across the board, and there are some other unusual findings when you start to look at lymphoid infiltrates and their numbers comparatively with survival across some of the other cell types, which we'll talk about. So this brings us really to the application of the colorectal carcinoma Immunoscore, which is a rather large international initiative which looked at approximately 4,000 patients with colorectal carcinoma, and it was shown, or at least published, to predict prognosis with early stage 1-2 disease. And the staining for this colorectal carcinoma Immunoscore is very basic. This is, of course, technology we've been using for 20 years now. You essentially look at two slides. You stain one with CD3 and one with CD8, and then you do a whole slide scanning and digital analysis. So there is an older technology matched with some newer technologies right here. And what you do is you essentially train a classifier to pick up the invasive margin, which is delineated by the arrow, and then you have a central tumor. So this is into the tumor, and then you have the more normal tissue or normal stroma, which is behind the tumor. And you look at within 360 microns of the tumor margin, both in and outside. And essentially, what's shown here is that you essentially look at a density distribution and compare that to a training set distribution, and you give a score based on the average percentile class. And so you basically have two variables. You have CD3 and CD8. You have away from the margin and then within the margin. And so you get, if all four of those are within the high margin of the training set, you have an Immunoscore of 4. An Immunoscore of 3 gives you 3 of the 4, 2 of the 4, 1 of the 4. And those that are in 3-4 category have a good prognosis, an intermediate prognosis with an Immunoscore of 2, and a poor prognosis with an Immunoscore of 1. So it's relatively simple. And if you have any digital pathology capabilities, you should be able to do this with just a basic scanner. I think even the Aperio software will allow you to do some of these functions. So, but there are so many different cells that are within the tumor microenvironment, and they have both anti-tumorigenic and pro-tumorigenic functions as delineated here. And so historically what we've done is recognize that these cells are there, but we have very little functional data on what they're doing, and certainly the studies that will follow this up will have more functional markers on top of cell delineation markers, and we'll show you a little bit of that later on. So I'll run through a few of these markers and then give you a summary slide to show you what's going on. So these are tertiary lymphoid structures that people have been noting for many years in their tumors. These are lymphoid follicles with a T cell zone, a mature dendritic cell, and a central follicular zone with B cells actively proliferating in the germinal centers. Lower numbers have been reported in renal cell carcinomas, but the number of these has a positive survival correlation in a host of tumors and a negative survival correlation in hepatocellular carcinoma. And this is just an example of one of those lymphoid follicles, and the magenta actually is marking PD1 cells within the follicle center area of this tertiary lymphoid structure. Treg cells, which have a variety of functions within the TME, including secretion of inhibitory cytokines. They can target and shut down dendritic cells. They can cause metabolic disruption of the T effector cell. They can actually induce cytolysis of the T effector cell, and they can compete for the time of dendritic cells here. They've shown a negative survival correlation in a host of tumors. And then you start to see some of these odd and unusual trends here with a positive survival correlation in colorectal carcinoma and gastric. It's a little bit unusual to see that. It might be that actually the ratio of the effector T cell to the regulatory T cell is more important than the absolute numbers, and certainly many of these MSI colorectal carcinomas have a massive number of leukocytes in the tumor microenvironment, which would include regulatory T cells. It certainly deserves some more study and attention. Macrophages end up being an extremely complicated cell type, much more so than what we look at as regular diagnostic pathologists with CD68 and CD163. There are a variety of subsets of these, which can be, just to give you just a brief overview, the M1 subtype was named in that it has similar function to the Th1 type of subset of T cells. So these secrete pro-inflammatory cytokines such as TNF, IL-1, 6, 8, and 12. So you would expect that the pro-inflammatory flavor of macrophages would have a more favorable outcome, and in fact, the more of these that you see in these tumors here, the better the outcome. And the M2 is really an anti-inflammatory macrophage, although there are 3 variants of M2 macrophages. They secrete IL-10 and TGF-beta, and increasing numbers have an unfavorable prognosis in a variety of tumors. And then what we can see in the center here is this exhausted CD8 TIL cell. And this is a paradigm which came out of the LCMV models and chronic viremia models in mice, in which the chronic antigen-stimulated CD8-positive T cell develops defects in its function, which can be from a variety of causes, either chronic antigen stimulation or defective CD4 cell help, or engagement of inhibitory receptors on this exhausted CD8 T cell, or functions that put it in touch with suppressive cells like myeloid-derived suppressor cells and TAMs. But we have a variety of ways to pick up expression, as you know, by antibodies in the tumor microenvironment, many of these markers. And then there are numerous therapeutic strategies which are coming down the pipeline as well to help reinvigorate those exhausted CD8 TILs so that they can do their job. And this is a very nice review of data from 200 studies, which is weighted in such a manner that dot size of small is 0 to 100 patients, of medium is 100 to 1,000 patients, and the large dots are 1,000 to 10,000 patients. And you look at tumors versus the immune infiltrate and prognosis, with the greens being positive prognosis and the reds being negative prognosis. And when you line up many of the markers that I just discussed, the CD8 T cells, the tertiary lymphoid structures, the Tregs, the macrophages, many of these tumors fall into the predicted results. So that is the higher the level of CD8 T cells and tertiary lymphoid structures, the better their response. And the higher the level of M2 macrophages, the worse the response. But you can see that it's not universal across tumors. Again, this is a recurrent phenomenon, that a lot of this is tumor specific. And when you look at renal cell carcinoma, as noted, the infiltrate of CD8 T cells actually has a negative prognosis, and we're really unsure as to why that is. There are some other notable exceptions as well, as we talked about in colorectal carcinoma. The number of Tregs actually is associated with a better prognosis. It might actually be a better surrogate of the total inflammatory infiltrate than it is of the absolute FOXP3 regulatory density. So, and you can see that there are numerous markers that have no effect, and then many holes that need to be filled in as well, places where we can contribute to pushing back the frontiers of ignorance. So, currently, I'll basically switch over to talking about PD-L1 expression, and we have a little bit of PD-L1 staining in multiplexing that I'll show you as well. But you know, I hesitate to do this. I worked in PD-L1 before I came to Memorial, before it was a companion diagnostic, and when I got here, I said I was generally uninterested in PD-L1. So I apologize now, because I was screening dozens of hybridomas on tissue. They were all the hybridomas were shown to be specific by flow cytometry to pick up PD-L1. And what I noted after looking at like 20 or 30 antibodies, and this was maybe 8 years ago now, is that there was a massive amount of variability in the staining that you saw in tissues, in control tissues. And in general, I thought that it was far too complicated at that time to figure out. And after a year and a half or so of sunk time, we published nothing out of it. And then I came to Memorial, and everyone was so excited about PD-L1. And this was right before they released the companion diagnostic. I said, no, thank you. And now we're left with the same problem, which is still trying to figure out what is the appropriate pattern of PD-L1 and what are the best antibodies. But what I'll talk about is how we got here. So the early PD-L1 prognostic data in nivolumab looked at 39 patients with mixed solid tumors with PD-L1 staining in the pre-treatment tumor, which showed that if you set a threshold at 5%, those patients that were positive were twice as likely to respond, and this was confirmed in numerous diseases. And then when you do PD-L1 pretreatment meta-analysis, patients with anti-PD1 response without PD-L1 data are as follows. So there's a 29% response to anti-PD1 in 15 studies across various tumors. And if you stratify that response by PD-L1 positive tumors, 48% that are PD-L1 positive respond and 15% that are PD-L1 negative respond. And this is essentially what happens when you start at 2012, which is the entirety of essentially most of the large series up till about 2014. So this was the early data that predated the companion diagnostic test. And this is the number of patients, objective response rate. Everybody over here got an anti-PD1 antibody, and it was scored in a membranous pattern on tumor cells. Everyone over here got anti-PD-L1 antibody for treatment. It was looked at in the immune infiltrate. And this was really what happened. So in the beginning, in the very beginning, all of the patients who were PD-L1 negative had no response, and those that were PD-L1 positive had a 36% response. And this started the hysteria in looking at PD-L1 essentially in tissue. And so what happened in essentially all of the follow-up studies is you saw that there were a significant component of the PD-L1 negative population that responded to these trials, and we never got down to 0 and positive. And so it ended up becoming a complicated biomarker in which was more complicated by the fact that it was pushed through as a companion diagnostic in multiple contexts with different approved antibodies. So in October of 15, the FDA approved PD-L1 companion diagnostic for Pembro, the 22C3 monoclonal for squamous and non-squamous lung cancer, with a pretreatment tumor threshold of 50%. Those patients that were positive had a higher response rate, prolonged progression-free survival, and overall survival. And then with Nivo, there was an FDA-approved companion diagnostic that was not required using a different antibody, 28/8. And when you looked at non-small cell lung cancer, squamous and non-squamous, it only improved overall survival or it was seen to have a better prognosis in the non-squamous group. And positivity in this case was greater than 1% tumor expression, which is a massive difference compared to the 50% in the prior companion diagnostic. And the RCC trials have been quite conflicting. So what we were left with at the time was recommended assays based on the therapy, and you can see that the antibody clones were 22C3, 28/8, SP263, SP142. There was some differences in platforms. There were significant differences in the cutoffs and also in who was expressing in either TIL or tumor, which set off a big frenzy in the field a couple of years ago in that the monoclonal antibodies differed, the staining platforms differed, the interpretation parameters varied, and then there were a variety of pretreatment sampling variabilities that people were concerned about. And so this set up what was called the Blueprint Initiative, which was supposed to be a collaborative initiative between pharma and academics, which very early in its inception was criticized by David Rim and colleagues because, and legitimately so, nobody in this initiative wanted to actually correlate their antibody with patient response. They only wanted to correlate between antibodies and show the comparable patterns. And so the group actually fractured, and we have the follow-up, which was published in 2017. So RIM published with colleagues looking at 4 antibodies and 90 non-small cell lung cancer tumors that the outlier within this PD-L1 antibodies is SP142 with the lowest score, although we don't know what the actual clinical impact is really. The 22C3 was slightly lower than the other 2 within here, and that there was a very high tumor score concordance between pathologists, but a low concordance rate if you looked at scoring the TILs. So certainly there's a lot of need for more objectivity when looking at TILs, and this was one of the first indicators that this is true, which certainly legitimizes the need to do digital pathology assessment of this and more quantitative mechanisms. And then the Blueprint core group looked at 39 non-small cell lung cancers, and they essentially found exactly the same results as RIM colleagues. So this was the mid-2016. We thought that the biomarkers of clinical response to PD-1 were going to be PD-L1 expression, mutational load, and CD8 T cell density. And then within 6 months of this being published, there was a massive move forward in what was presented in ASCO 17, which was that the gut microbiome actually might be a fantastic biomarker for response to PD-1. And this is all based on data from the mouse, which looked at murine melanoma studies. These mice were treated with anti-PD-1, and the ones that had more bifidobacter essentially had increased anti-PD-1 tumor activity. And when you looked at mouse and human sarcoma studies with anti-CTLA4, those mice that had higher levels of bacterioid therapy did better than those that didn't. So what was presented in early this year essentially was that metastatic melanoma patients, when you looked at pre-PD-1 sampling of the gut and oral flora, those patients who had a diverse gut microbiome had an increased progression-free survival, and this was correlated with increased levels of Clostridialis, the Ruminococci family, much more so than Bacteroides, which suggests that there's also significant differences between species, which could be predicted, but we need to focus more on human studies. And now almost every study that I've sat on the planning is trying to incorporate some element of fecal stool assessment prior to therapy and on therapy. So yeah, lucky us. So other biomarkers for immunotherapy that I haven't spent too much time about is viral proteins. So there's evidence suggesting that there's a positive response of viral-associated tumors to anti-PD-1, with Merkel cell carcinoma being one of the good examples. The overall response is 56%. That's just because the virus positives has 62 and the virus negatives have 44%, which brings us really to what I spend most of my time doing, which is how can we improve the historical usage of chromogenic immunostaining and looking at populations using new technology. And so we have this platform which we're looking at right now, which is a fluorescent-based platform that you can do all of your staining for 6 markers on the Leica Bond instrument, and then you can load an automated scanner and you can get beautiful pictures across cohorts relatively quickly, like this one. This is pancreatic adenocarcinoma right here, which there's an assortment of markers, and you can see that a lot of the green looks yellow, so you'll see appropriate localization of CD3 and CD8. You can get an idea that in this pancreatic tumor, there is quite a bit of PD-L1 expression, but it's quite variable across just this 20x field of view right here. Most of it is not in the tumor. Most of it's in the tumor microenvironment. And then we can do a lot with both spatial analysis and co-expression. So I'll show you some data from a small initial cohort that we ran. But just here, you can see that there are quite a few FOXP3 regulatory T cells, but some of them are expressing ICOS, and many of them are not expressing ICOS. And you can do neighborhood profiling to compare neighborhoods like this with those up here. This is a very well-established platform. It's based on the PerkinElmer Vectra. It's also a good workhorse, and it's relatively reliable. And it has a digital pathology component of it built in, where you can start to generate cell-by-cell data and then take that offline to work with your bioinformatician or systems biology people to look at these more advanced spatial relationships and neighborhood profiling that you see here. So what I'll show you is we started this platform in about December of last year, mid-December. And we transitioned over to the LICA-bond staining in about May or so, and we ran a pilot cohort through here in May, which looked at 21 cases of pretreatment biopsies. All these patients went on to get PD-1 blockade after biopsy. And what we have is 6 patients who had stable disease, 3 with partial response, and 12 with progression of disease. And we can break down these non-small cell lung cancer patients by disease type. Most of them are adenocarcinomas. Second most common group is squamous cell carcinomas. We had 2 outliers with mixed lineage tumors, which we included kind of for fun. But we built this panel to look at the glucocorticoid-induced TNF receptor here, which has been in trials for years at Memorial, and we're not entirely sure how to use it combinatorially. And this has complex functions. It was thought to be a predominant regulator of regulatory T cell functions. Upon ligand engagement, you see decreased Treg suppressive functions. You see increased T effector resistance to the Treg suppression. And basically, there's been preclinical benefit, which is shown in multiple solid tumor models, with increased benefit over monotherapy in PD1 or CTLA4. And so we built out just a very small panel right here. So this platform does 6 antibodies plus DAPI. It's a 7-color panel. We have a beta platform that we received about a year ago that we've been working on with GE that can do up to 40 markers in tissue, but it takes a lot longer to stain it. And then we're looking forward to another platform that'll be arriving within the next month or two, which will be able to look at between 40 and 100 markers in the same tissue section. This is all antibody-based staining in the beginning, but there certainly is an application to build in situ, and we've done in situ hybridization plus antibody staining on the PerkinElmer Vectra here. But we wanted to look at GITR expression in non-small cell lung cancer tumor microenvironment on the regulatory T cells versus other cells. We wanted to correlate this with PD-1 treatment outcome. We wanted to look at co-localization of the proliferative marker Ki67 in the CD8 populations. We wanted to look for FOXP3 outside of the context of GITR expression and how it related to CD8 in regards to ratios. And then we also wanted to look at IDO expression by both the tumor and the tumor microenvironment. And you can answer all of these questions with a 7-color panel shown here, including many others when you start to look at spatial features and relationship of TIL to TIL or TIL to tumor as they're expressing these markers. So it really requires a significant amount of bioinformatics support. But this is what the panel looks like. So the red is all tumor, and you can see in the top left panel, you're seeing co-localization of FOXP3 and GITR up here, co-localization of Ki67 and CD8 right here, and you can see that there's a variety of other cells that are co-localizing for Ki67 and CD8 as well. And what we see as pathologists when we look at these infiltration patterns is very interesting. There are a subset of tumors right here that can show very tight approximation of the CD8 and GITR positive cells with tumor. Many of them were within the tumor body. And then we have tumors here where the CD8s are just relatively bored. So they're just not interested. And then we have some in-between categories where we have the CD8 and the GITR positive cells and the FOXP3s, which are approximating the edge of the tumor, and we have those that appear to be attacking the edge of the tumor. And with the more advanced panels, the more you stack, you'll be able to look at functional markers that are being expressed or not expressed by the tumor and their relationship to tumor microenvironment. And then we use digital processing tools right here to pick up what is tumor and what is microenvironment, and it's doing a very good job of picking out the keratin positive tumor right here. And then these are the raw images that come off of the machine with the stacked markers, and we can use additional tools to break this down and train algorithms to pick up individual cells, and then also to threshold the message appropriately within those individual cells, such that when you export this data, you have single cell data with location and expression profile, both absolute and also thresholded. And so this is what we see in this very small cohort. Each bar is a graph. This is just GITR positive cells per millimeter squared of stroma. It's broken down and colored by tumor type and also by outcome. This is stable disease, PRs, and progression of disease. And in GITR positive cells per millimeter squared of stroma, we don't see too many trends between SD, PRs, and PODs, but we do see these outlier groups. And two of these outliers are the more unusual mixed lineage tumors. One is an adenocarcinoma. And of course, you always want to go back and check your outliers to make sure it's real staining. In fact, it is real staining. We see an enormous GITR infiltrate in this tumor microenvironment here, although interesting, most of them are not co-expressing FOXP3, so it appears to be in another lineage like our helper T cells. And so then when we look at GITR expression and response to PD1, we see exactly what I showed you right here, that GITR positive cells per millimeter squared of stroma is not statistically different between stable disease and progression of disease. But what did come out, which was unpredicted, was that the GITR positive cells per millimeter squared of stroma actually is increased in the stable disease patients versus the progression of disease. And we've expanded this into a larger cohort, and we're putting this together as a little story. So when you look at CD8 positive cells, which is a more classic biomarker we've already discussed today per millimeter squared of stroma, it's interesting that just the stable diseases seem to, on average, have a higher level of CD8 positive cells per millimeter squared of stroma, but there's a lot of variability in this relatively small cohort. And so what you end up with when you look at the statistics is just an apparent trend to an increase in the CD8 positive cells per millimeter squared of stroma in the stable disease or also in tumor. And this is exactly what we see. We're going back and looking at some of the older biomarkers and comparing it for usage on these platforms. And the same holds true, but perhaps a little bit more visual distinction between them when you look at the double positive CD8 Ki67 cells per millimeter squared of stroma or per millimeter squared of tumor. So what we found lacking significance with response to PD1 are all of these variables that you see here, including co-expression data that would be very difficult to generate with standard chromogenic staining. Of course, we start with very good chromogenic staining, and then we transition those antibodies over to FFPE and validate them with the detection systems that we're using. And so the conclusions were that GITR was expressed in the tumor microenvironment of lung, adenocarcinomas, squamous, and mixed subtypes with wide range that certainly needs to be further explored. It's expressed on FOXP3 and other undefined subtypes, likely helper 4s. The GITR cells per millimeter squared of tumor correlate with PD1 treatment response, and then there's a trend towards response in the CD8s and CD8 Ki67 populations, both in stroma and in tumor. We've done the expansion cohort right now. We're putting that together with additional higher order analysis. And what we're hoping is that certainly these small panels can provide a huge amount of information, but as we look at 50 markers, which would include all of our potential targetable molecules for trials, on the same slide at the same time, it could help guide rational decisions for combinatorial immuno-oncology trials. We'd like to integrate markers of T cells, NK cells, tumor-associated macrophages, much like we've talked about, all on the same slide at the same time to save tissue. Of course, we create an enormous bioinformatics problem with this, and so we've collaborated with bioinformatics and systems biology to sort of work on a pipeline for analysis. And the real challenge, I think, at the end is how we integrate all of this, including, I should add, Michael's technologies here into the management of patients, which is becoming increasingly more difficult. And with that, I'd like to thank you for your time here. I'd like to thank Dr. Klimscher for the invitation. Dr. Hollmann's the oncologist that provided the well-annotated non-small cell lung cancer series, and then also the MSK faculty, trainees, and colleagues that I work with. Thank you.